Good evening, everybody. I'm Hannah McClung, and this is my enhanced case study on the cerebral palsy patient. Just a little client overview of MA. He is a 17-year-old teenager. He is 5'7", weighing 98 pounds, which, if calculated, his BMI is about 15.3, which is underweight and something to be mindful of. His blood pressure was 114/68 with his total cholesterol at 155 and his HDL levels at 55. And of course, he's been diagnosed with cerebral palsy. The only risk factors to really take note of in this chart, because all of his blood work and all of his labs seem to be looking really good, is that he has the CP diagnosis as well as his BMI is low, and it's something just to be mindful of. And you can see in the table to your right, he is a CP3 classification with cerebral palsy, and that just means that with this person, he's often in a wheelchair, but he is able to ambulate with a walker or some sort of assisted walking technique most of the time, but it's generally for short, intensities and things like that, and short instances. But in this case, it's just something that we need to take note of as far as creating his exercise prescription. And just kind of more of a cerebral palsy overview, it is defined as a non-progressive motor dysfunction present at birth or for the first 6 months of childhood. A lot of times it's caused by damage to the developing brain due to lesions, anomalies, or lack of oxygen to the brain during childhood. And these classifications are because you can see it across a spectrum of cases. I personally interned at a pediatric clinic, and I saw anything from a quadriplegic cerebral palsy patient as well as a child who was almost fully functioning with just mild abnormalities in his gait and things like that. So some physical limitations include hypertonia, that really tense muscle flexion, as well as spasticity, seizures, things of that nature. And there's also some cognitive limitations in certain cases that include things like ADD, ADHD, dysphagia, which is difficulty with speech, and things of that notion. So with the clinical evaluation of MA, he's a teenager, so he can be pushed, but the first thing I want to do while it's on the bottom of the page is to assess his range of motion, because there could be some things I would take note of, like maybe in shoulder flexion, he can only get up here and his elbow is going to be flexed the entire time, and he's not able to get to that full overhead extension or even close to it. That would be something to be mindful of. Things of that nature, as long as along the lines of his hip mobility as well, ankle mobility, things like that, that's going to hinder him from doing certain exercises safely and effectively. So due to his age and just the fact that he is only 17 and he shows no other risk factors, he's in no instance at any risk going to have a heart attack. So I opted not to do any cardiovascular fitness testing because I didn't deem it necessary. Of course, if I worked with him later on in his life, I would, about the middle age, then consider cardiorespiratory testing just to ensure that he is just optimizing his health in every way. But with resistance training testing, I decided to do the number of repetitions in 1 minute test, which included exercises such as the squat, Russian deadlift or RDL, and bench press, as well as shoulder press, bicep curl, and tricep extension. Now with these, I wanted to go into a little bit more detail because, of course, if any instance where MA is unable to safely perform these movements, I'm not going to delegate these as a testing measure. But in the instance that he is, there would definitely be, like for instance with the squat, he would be provided with a bench behind him that's going to keep him stabilized, it's going to keep him safe and secure, and that's not going to hinder his performance in any way, but it's going to make sure that he doesn't increase his risk for falling. Same thing with the RDL. The Russian deadlift will be done on a Smith machine where it's strictly a closed chained exercise, meaning his feet are firmly planted on the ground and there should be no instance in which he's unstable, and I'll be there spotting him as well. Same thing with the bench press. The bench press will be using the Smith machine to just help ensure protection. And while unilateral testing research indicates that it's more beneficial due to some range of motion limitations or co-contraction in certain limbs versus others, their safety is our utmost priority. So with things like the shoulder press, it could be done on the Smith machine. Bicep curl, tricep extension could be done on one of the machines where you do a tricep pull down. And bicep curls could be just really light weights with wrist grips or on a machine as well. Just whatever's most comfortable for MA. So as I've already kind of mentioned, there's some considerations to take into play whenever you're thinking about the clinical evaluation and testing as well as exercise prescription. So we can expect limitations in range of motion, that spasticity, that co-contraction, muscle weaknesses, all things that could hinder his ability to perform things effectively. So things such as low benches, wrist straps, hand grips, and any exercises where we can use the machines or where it is safer for us to use the machines, we're going to use those to ensure his safety and his adherence to the program as well. Because who's going to want to adhere to a program that makes them feel like a failure if they fall or hurt themselves? And as I said before, unilateral testing is best, but safety is our first and utmost concern. So this is kind of just a description of my program layout. The frequency is 3 times per week with myself in the clinic, and the intensity is done from the Borg scale. As you can see, I've shown it on the right with the RPE scale. I generally kept it within ranges of 10 to 16, and the time in which he spends with me is about 45 to 60 minutes a session. And the type is circuit-based training. So what I did is implemented into his warm-up was some sort of cardiovascular training, such as the new step is where we started. I incorporated arm ergometry, cycle ergometry, and walking progressively, of course, all of these things, to kind of give him a little bit of cardiovascular endurance work there. But also, I did his programming in a sort of circuit-based to help test his cardiorespiratory system as well. So he would complete 3 exercises, have his rest time, and then restart that entire circuit for the second set to kind of give him some cardiovascular benefits, but also just focusing mainly on increased muscle function, increased muscle size, and overall functionality, which was one of MA's goals. So with volume, I indicated it in the Excel sheet that you will see little clips of here shortly. By sets, reps, and load, I did not incorporate his warm-up cardiovascular training into the load because it stayed rather consistent throughout the entire program. And with progression, I first usually increased the rep range, and then to ensure that he was functioning at a, low weight intensity, functioning efficiently, and then progressed into higher intensities, which would be something like more weight or maybe not as assisted on my end, which is indicated by the volume tracker that I will show you all later. So this is phase 1, and as you can see, the warm-up is approximately 5 to 8 minutes, 5 in the beginning, progressing to as much as 8. I kept it with the new step and arm ergometry in this phase, strictly because the new step provides cerebral palsy patients the ability to push themselves, despite maybe hindrances in range of motion, and arm ergometry is just another method that he can use that's going to reduce the training monotony in his program. So we had 3 circuits in each block, as you can see. Day 1, day 2, and day 3, we had an A series, a B series, a C series, and a D series, which was strictly the cool down, which is the flexibility training. And to prevent you all from being completely bored to death and overwhelmed with an array of information, I just provided the first 3 days of the week. Because throughout the 4 weeks, I did minimal progressions and certain movements to help, again, reduce that training monotony, switch up exercises to keep things new, and also just to continue to try to do my best to make sure he is continuing to improve, to continue to build that strength as I see tolerated. So as you can see, we started off with a squat to bench assisted. So what's that meaning is we have really a high bench if needed to whatever height is appropriate for his range of motion. And he's going to be squatting to the bench, so he has that stability. And he also is going to have me as a spotter in front of him, potentially holding his hands, whatever the case may be, to ensure his utmost safety. And as the phase 1 goes on, he might progress to a squat to bench not as assisted, and he might also progress to a squat to bench with the Smith machine. You'll see these progressions along the entire 3-month program. And similarly, I incorporated balance exercises as accessory work, which started with just strictly standing to help him get more used to eventually doing walk training with me. And then I would eventually develop that into standing on an Eric's pad or single leg standing, and then single leg standing on an Eric's pad. All things that's going to continue to push him to become more optimal in that proprioception and helping him be able to stabilize himself whenever he's standing. With the shoulder press, I kept it safe at first with the Smith machine, and eventually in programs to come, you'll see that I transition into things like single arm shoulder press, which may be with really light dumbbells, and again, those sort of exercises will include those wrist straps, as well as me spotting him by his wrists and making sure that he's safe throughout the motion. And you can see I incorporated a lot of banded stuff initially as well to just help ensure that we're getting that body to go through the range of motion without putting too much stress on the muscles to reduce his adherence to the program. We want him to enjoy what he's doing and not feel like it's too challenging for him to come back. And as you can see too, I kept the flexibility training and the cool down all the same through the first 3 phases because I provided different options in each day. With the shoulder stretch, the quad stretch, and the hamstring stretch in day 1, that's things I can do passively. So I can stretch him, which could help me push him to further ranges of motion. And then there's other days where he can do things such as trunk twist to work on that trunk flexion, extension, and rotation, arm circles, and the arm across chest stretch, And then on day 3, hip flexor stretch, seated hamstring, PVC shoulder stretches, just things that he can do on his own as well that I would encourage him to do on his off days. Now phase 2, it's all the same layout, so I won't continue to explain that as much, but you can see the progressions of the exercises, and it continues to progress throughout the other 3 weeks as well. I failed to mention in the last block that every 4th week of my phases I have a deload week, and that's going to help them adapt to training and help their body heal completely so we can increase that RPE, we can increase that intensity even more from the start in the next training load. And in his warm-up, they're now 8 to 10 minutes long, with including new step, arm ergometry, progressing to cycle ergometry, and some walk training as well. And then we continue to see the squat progressions. He's now doing bodyweight squats without the bench, and then this is going to help him do practical daily life things like getting on and off the toilet independently. And I'll still be able to provide him a spot in the front, but you can see how he progresses with that, as well as movements like the bench press. We see he's progressed from a banded glute bridge to a med ball glute bridge and continuing to just really encourage him to become more independent. And you can see the RPE intensity increased from, I kept it around 10 to 11 the first time, and now it's about 12 to 14. Phase 3 is continuing the same thing. We generally are doing walking at least once a week, most of the time twice, with more practical movements. We're doing a full back squat on the Smith machine now. And we continue to increase those intensities because he is a teenager, so we can increase his intensities to near maximal effort to really help ensure that he's pushing himself and making sure that he's getting utmost work out of his exercises. And everything else stayed rather consistent. We increased stabilization exercises with things such as glute bridge marches and things of that realm. This is the volume tracker that I mentioned earlier in the presentation where I can monitor what we're doing throughout the week. As you can see, he has increases in training load and then he has a deload week. He's got a little variation in training load. We spike, deload week. Same thing here. We're up here, deload week. So that's going to help him really adapt to the program and not feel so tired and worn down. It's going to help his body heal so he can adhere to the program. Just a reminder of the justifications we talked about through the entire presentation, how I would first assess range of motion to ensure what exercises are safe and attainable for MA, as well as providing those things like low benches, hand grips, and torso straps to ensure that he is safe. And just to continue to progress in exercise types that were made based on how MA tolerated it, because CP is heterogeneous and it is something that we have to be mindful of when programming for our individual. So that's all I have today, and thank you all for listening.